Hello, everyone. Uh, this is Dr. Desalegn, Critical Care Fellow from Ethiopia, St. Paul's Hospital, Millennium Medical College. I'm moderating today's seminar on right heart failure, etiology, and management, which will be presented by Dr. Thomas. We're really honored to introduce and invite Dr. Thomas, who is an internist and consultant pulmonology and critical care physician. Currently, he's working in Inova Fairfax Medical Center, and he is an assistant professor of medical education at the University of Virginia School of Medicine, and clinically he works with advanced lung disease and lung transplant and medical critical care groups. We're really pleased to have him on board to give us lecture, which is very relevant for us. So having said that, I would like to invite him to start the presentation.
Great, thank you so much for that nice introduction. Let me share my slides here. We'll get started. Okay, great. So thanks again for that nice introduction. I'm really happy to was asked to speak about right heart failure, etiology, and management in the ICU. If at any, I don't have any relevant disclosures or conflicts of interest for this talk. If at any point there's any questions or discussion points, please feel free to interrupt me. I can't see the chat, so just unmute and speak up, have a discussion. Real quick before we get started, I realize some of you may not know where Inova Fairfax is, so I thought I'd just show you a little quick introduction where I work. This is a map of Washington, D.C., our nation's capital, and Inova is located about 10 miles due west here out in northern Virginia, right outside the Beltway, if anybody's familiar with this area. We don't have quite the brand recognition of Johns Hopkins, I don't think, globally, but we're a really big medical center. We're over 1,000 beds usually. We have many residency and fellowship programs, including internal medicine and cardiology. We're a large clinical site for the University of Virginia. One fun fact is I think we're the fourth busiest emergency department in the whole United States. And we have a lot of advanced programs. We do heart, lung, kidney, and bone marrow transplants. We have a very big cardiogenic shock program and a lot of research initiatives in cardiogenic shock, heart failure, pulmonary hypertension, that types of thing. So I'm privileged to work here, and I'm proud to work here. So just briefly, what I'm going to discuss today, we'll do a little bit about the normal structure and function of the right ventricle, and then discuss some different ways that the right ventricle can fail. And as I was learning this, I tried to create a conceptual framework for that. So hopefully that's helpful for the fellows to think through some of these problems that you see commonly in the ICU. I'm going to discuss some sort of general principles of care. There's a really big bucket of ways that the RV can fail and reasons why. And every case is a little bit different, but I want to discuss some general principles that apply to most cases of RV failure in the ICU and critically ill patients in general. And then for the second half of my presentation, I have a case. An interesting case of a patient we took care of here at Inova about 2 years ago that I think illustrates a lot of the important points from the talk, and I hope it makes it a little more interesting rather than just a didactic the whole time. So again, if there's any questions or anything, please speak up. And so the right ventricle, in contrast to the left ventricle, you can see over here, it's a much less muscular but more compliant structure than the LV. You can see the walls are thinner. But despite it being smaller, less muscular, it needs to have the same stroke volume as the left ventricle. By definition, every beat of the heart, it needs to push the same amount of blood through the lungs as the LV pushes through the body. So it's a very different structure, even though it's intimately linked with the LV. Because the afterload or the pulmonary artery, the lung resistance is much lower than the systemic vascular resistance, the RV has to do only about 25% of the work on every stroke as compared to the LV, mainly due to this lower afterload. And just for reference, the mean pulmonary artery pressure, the afterload of the right ventricle is somewhere around 10 to 15 millimeters of mercury normally, whereas the systemic map can be, 70, 80, 90, or even higher in the LV works. So very different environments that these ventricles are pushing into. And the function of the right ventricle is also different than the LV. You know, it's kind of this combination of longitudinal shortening, you know, as the heart contracts, it squeezes this way, but also some circumferential shortening. And I'll show you some 3D structures here in a second. And the RV is very interdependent with the left ventricle, and it's because they share a septum. The septum is part of the motion, and then the shared septum attaches to the RV free walls, you know, anteriorly and posteriorly. And there's all these mutually encircling epicardial fibers, and of course they all both ventricles share the pericardial space. So there's a lot of interdependence going on here, even though they have sort of very different ways of functioning. And then I put these pictures here to help you just understand a little bit more three-dimensionally what the right ventricle is doing as opposed to the left ventricle. I have some echoes later, which will show kind of how it fails. But on the left side here, this is kind of normally what it looks like. We can start up here. The LV is this nice sort of bean-shaped cavity, and it's very muscular, and its one job is to just shoot blood out at a very high pressure, whereas the RV is sort of wrapped around here, and you can see the tricuspid valve inlet here, and then pushes blood out through the pulmonic valve. So you can see they're very different structurally. And then this cross section is the same thing as up here, just a little bit rotated, but the LV is very circular, muscular, and the RV just sort of wraps around the side. So as we see in ways that it starts to fail, getting to a little bit as the pressure goes up, the septum tends to bow over. And for a time, the heart can sort of adapt to this, but as we'll see in ICU cases, it becomes uncoupled and fails to function. And also the RV tends to balloon out with volume overload. So it's a very sort of dramatic change in both the shape and size of the RV as it begins to fail. So as I was saying, it's the right ventricle and coupled to the pulmonary artery in the lungs is a very low pressure, low resistance, but high flow system. And for those reasons, it's very sensitive to changes in preload and afterload. So by preload, blood flowing in there for whatever reason we'll talk about, and then changes in afterload. Any issues with the pulmonary artery or lungs can very quickly cause this RV to fail. And especially acute changes, the RV doesn't have any time to adapt. So it can fail pretty quickly in acute instances, like we'll talk about. And then one way to sort of think about this as we move into failure mechanisms is that it's the RV itself, and it's very much coupled to the pulmonary artery. And it's adapted. In some diseases, like for example, pulmonary hypertension in the lungs that develop over years, the RV can become very abnormally enlarged and hypertrophied, but still function fairly well because it's coupled and it's had time. But in other diseases like acute pulmonary embolism, if you block off a large portion of the pulmonary artery, the RV just has no choice but to fail because it doesn't have time. And if you change the afterload very quickly, the RV would. This is a pressure volume loop of the RV versus the LV. You can see here, during systole, the blood is ejected in the same exact volume in both the RV and LV. That's by definition, for continue to function and for the RV to provide blood to the LV, the same amount sort of has to go out with each. So the cardiac output of each ventricle is the same, but it does it at a much lower pressure gradient. It's only changing maybe 10 or 15 millimeters of mercury, whereas the LV can generate really high pulse pressures, like 60, 80, 100, to do the same amount of work because of the high afterload. And I'm sure many of the fellows are familiar with the pulmonary artery catheter, but this is sort of the best way to assess the volume status, the function, and the cardiac output of the right ventricle in the ICU. So I'm going to show some very abnormal numbers and waveforms a little bit later. So I thought it would be good to just quickly review the sort of normal pressures and waveforms. So the catheter is usually put in through the internal jugular vein, but you can also put it in, through the arm or the leg and make its way up into the SVC or IVC into the right atrial junction. So this is the right atrium. This is kind of your normal waveform in the right atrium. That should be pretty low, definitely less than 10 in a normal healthy person, probably, somewhere between like 3 and 5. Then you go through the tricuspid valve and you're in the right ventricle, and that's when you start seeing the pulse pressure of the right ventricle. The way you're in the right ventricle by looking at the waveform is you start to see these waveforms, and again, normally it should be about maybe 25, but the diastolic pressure should be about 0. That's the way you're in the right ventricle. And then you move through the pulmonic valve and you enter the pulmonary artery. And the way you know you've moved from the right ventricle to the pulmonary artery, the systolic pressure should be about the same, but the diastolic pressure should go up noticeably. Go up from 0 to 5 or 10, but otherwise the waveform is somewhat similar. And then with the balloon inflated, you can continue to advance the catheter, and it eventually wedges here in one of the smaller, maybe 1 centimeter pulmonary arteries. And with the pressure transducer distal to this, there's no longer any flow going through here, and no pressure is coming from here. So what you see is a waveform which is actually back pressure from the left side of the heart. So this so-called wedge pressure, which again normally should be maybe 8 to 10-ish in a healthy person. This is a diagram over here of what you're measuring. There's no flow here, so you're just purely measuring pressure minus the resistance component. It's the left atrial pressure, which, when the mitral valve is open, it also kind of equilibrates to the left ventricular and diastolic pressure, which is a surrogate for LV preload. And then also using this pulmonary artery catheter, you can calculate the cardiac output, either using the FIC or the thermal dilution method. And then using the mean pulmonary artery pressure, which you measure in the wedge pressure, you can calculate the resistance across the right-sided system, and we call that the pulmonary vascular resistance. So I think this is probably a review for most of you, but when I show some abnormal numbers later, it'll be important. So thinking about some ways the RV starts to fail, I took this nice table actually from a very recent publication in the Journal of Heart and Lung Transplantation, Journal of Heart and Lung Transplantation from just a few months ago, that really nicely sort of categorizes the different ways the RV can fail. So I mentioned that it's very sensitive to preload and afterload. So basically any derangement in preload can cause the RV to fail, any derangement in afterload, and then also the pump itself can fail for a number of reasons. So preload, the most common cause of RV failure is just your kind of garden variety left ventricular failure. So, we all know that when a patient goes into left heart failure, they retain fluid, they become hypertensive, and that the RV sees that both back pressure, from the LV and also just total body congestion. So the venous system becomes very congested and the RV bows out and it fails. If you have problems with, primary problems with the tricuspid or pulmonic valve, the right ventricle is going to have a lot of trouble with that. And again, it's going to become fluid and pressure overloaded and will eventually fail. And then any cases of left to right shunt, I think the classic case here is like a ventricular septal defect. So every time the LV pumps, some large percentage of blood, instead of going out the aortic valve, is going to come into the right ventricle and cause a lot of pressure overload and flow overload, and eventually the RV will fail from that. So those are kind of the preload categories. And again, it's good to put these into different buckets. So then when you're seeing a patient, you can kind of try to think about, which category they fall into, because they fall into multiple categories. Another category that I'm particularly interested in my clinical practice is excessive afterload. So diseases like pulmonary arterial hypertension, chronic thromboembolic pulmonary hypertension. These are more chronic diseases where the RV for a time is adapting and coupled, but then eventually it can fail. And then things that I'm sure the fellows have seen a lot of, things like acute respiratory stress syndrome. It's a primary lung problem with hypoxemia. You get hypoxic pulmonary vasoconstriction and the pulmonary vascular resistance goes way up. Then things like acute pulmonary embolism, you just put a clot in the pulmonary artery and the RV is immediately seeing very high afterload. It, can cause shock and RV failure. And I'm not going to talk so much about this, but there are many things that can cause, the RV muscle to fail without any, afterload or preload issues. So, patients with cardiomyopathies, patients with, long arrhythmias, and RV infarction, so like a right coronary artery myocardial infarction, myocarditis. I work in the cardiac surgery ICU a little bit, and we see a lot of RV failure after cardiac surgery. Patients go into surgery and they have a RV that is in great shape to begin with, and then you give the heart cardioplegia for a few hours. It's the RV is very sensitive to these sort of derangements, and then other primary cardiomyopathies, but I'm not really going to talk about that. But I think this sort of categorization is what's important, and it's as you see a patient, if it's an afterload problem, you want to focus on reducing the afterload. If it's a preload problem, you want to focus on reducing the preload and fixing the problem. This is another slide from another review. It's basically the same thing as I showed you before, but a little more of an ICU focus. So there's focuses on pulmonary hypertension or afterload problem, and then causes of kind of RV failure, pump failure itself. So pulmonary arterial hypertension is a very rare disease, but we see it a lot at my center, and these patients can become very sick. elevated left atrial pressure. So anything wrong with the left ventricle can cause the right ventricle to fail. So mitral valve disease we see a lot in the cardiac surgery ICU, left sided myocardial infarction. But really, this is a left ventricular problem. So if you fix the LV, the RV should follow. Hypoxemia from any cause, so pneumonia, ARDS, patients with chronic lung diseases like COPD or IPF that have exacerbations end up in the ICU on a ventilator. They, get hypoxic pulmonary vasoconstriction globally, and afterload to the RV goes way up and can cause the RV to fail. This is probably the most common cause that you might see in a medical ICU. Thromboembolic disease is also quite common. Acute PE, I'm sure all the fellows have seen this many times. And then more chronic PEs like CTEPH can also cause this. And then rarely, types of emboli, amniotic fluid embolism, that's pretty rare, but you need to be suspicious of this in the right patient. Cement embolisms, I've seen that before in post neurosurgery patients who get spine cement, air embolisms. These are all rare, but they can happen. And then it's pretty tough to do this, but patients who are mechanically ventilated on really high pressure, so really high PEEP, really high plateau pressures, just increases the intrathoracic pressure and causes high RV afterload and can cause the RV to fail. And then I sort of already talked about this, but primary RV failure, so issues with reduced contractility, infarction, sepsis can cause kind of an acute cardiomyopathy, myocarditis, pericardial effusions, tamponade. I don't really think of that as RV failure, more it's kind of something, but certainly you want to be aware of that. And then volume overload, so valve problems and shunts, that type of thing. So this is just basically the same as the last time, but just more of a ICU flavor to it. Just wanted to talk quickly about this RV PA coupling mechanism. And this slide I like because it kind of shows some pictures. So this is usually the case of how the RV adapts and then fails in pulmonary hypertension. So pulmonary hypertension is a progressive disease over many years, and patients often don't know they have it for a long time. But what happens is the pulmonary arterioles remodel and the pressure goes up, and for a time the RV can adapt. What happens there is the muscle kind of gets a little bit thicker, it gets a little bit dilated, and the contractility goes up. So the RV given time can sort of get more muscular and improve. But then as things progress, in order to maintain cardiac output, the RV has to dilate more, the heart rate has to go up, and then this results in an increased wall stress. Again, the septal bowing, you can see going over to the left side. It increases oxygen consumption and, basically doing more work. And then finally, eventually this can't really happen anymore. The RV can only adapt so much. And it starts to fail. So it's seeing more and more higher pressure, and it just can't eject blood. I'm going to go through sort of what we call the RV death spiral here in a minute, but it can't eject blood. And then for multiple reasons, not enough blood going through the lungs, septal bowing, the LV then cannot do its job because it doesn't have enough preload, and then the LV fails, and that's cardiogenic shock, and that's a life-threatening problem. I want to take a little bit, I like this diagram. There's a lot out there if you're curious in sort of the more detailed mechanisms of how the RV fails. So again, it's going to be a little bit different for which bucket, a preload, afterload, pump problem. This uses the example of high PVR, so any afterload issue for the RV. But basically, as the afterload of the RV goes up, you first get pressure overload. The RV can't fully eject, so it's going to start getting dilated. And I already showed you that loss of RV PA coupling. Because it's dilated and the pressure goes up, the stress across that thin wall is going to become really high. And then the coronaries are trying to perfuse that muscle, but if it's really dilated and stressed, you're going to get reduced coronary perfusion. As the RV is dilating, the tricuspid valve sort of functionally comes apart, and you're going to get a lot of functional TR. So that's going to further, reduce the amount of RV forward output that you can create, which is just going to cause more congestion and edema. All of these things lead to basically the RV becoming ischemic, which further reduces contractility and ultimately reduces cardiac output. And it's kind of a vicious cycle, and it can happen at different speeds. If someone has a PE, this can happen in 30 seconds, or someone who has pulmonary hypertension, this can happen over years. But eventually, it all sort of culminates in a reduction of cardiac output and cardiogenic shock. And these are the patients that are going to wind up in the ICU, and you have to figure out what's going on and try to fix them. I wanted to introduce some sort of like general principles. It's going to be very different depending on what the cause of the RV failure is, but these are some general guiding principles that should apply to most patients. And then as you're trying to figure out the etiology, you're also kind of thinking about all of these things. So First, in the algorithm, you want to diagnose the patient properly with right heart failure. You want to ensure appropriate monitoring. We're going to talk about some monitoring devices, but that may include a PA catheter, of course, full ICU monitoring with oxygen and heart rate and all that stuff. This said, avoid intubation. We'll talk about intubation a little bit later, but avoiding positive pressure, as I mentioned, that can kind of further worsen afterload. And then if you're at your center, you're not quite as experienced in this, you may want to reach out to a more experienced center that has a higher volume with these patients, if that's available to you. Then you want to look at your patient and know as much about their medical history as they can. If you know they have a problem like pulmonary hypertension, it's probably due to that. But if not, you want to look at them for other issues. You want to treat it, diagnose and treat any infections, arrhythmias, PE, et cetera, and administer supported therapy. For that, you want to optimize the fluid status. Most patients with right heart failure are fluid overload, but it's not always the case. So you have to do sort of a careful exam and evaluation. Patients with right heart failure can also develop sepsis and things that need fluids, as you know. So it's not a hard contraindication to giving fluids to these patients. You just have to understand sort of the right clinical situation. And then I kind of keep hammering home these buckets, but then, those buckets are kind of the way you want to address each of the issues. So sort of a hallmark of managing RV failure is reducing RV afterload, sort of in the same way as in a left heart failure patient, you want to dilate them peripherally. In the RV, you want to decrease the pulmonary vascular resistance. Acutely, I'll talk about some of these drugs a little bit later, but inhaled nitric oxide or inhaled Velitree is one. We don't really use prostacyclin or pH drugs in the acute setting. These are more long-term meds, but in a crisis, you could sort of consider them. But something like inhaled nitric oxide or inhaled Velitree is something that can really quickly get your PVR down. Also, oxygen is sort of one of the most underrated pulmonary vasodilators, but if your patient is hypoxic, getting them on a lot of oxygen can actually really help reduce their PVR. Then you want to optimize the cardiac output of the ventricle itself. So we're going to go through some inotropes here in a second, but increasing the squeeze however you can with meds like dobutamine, milrinone, epinephrine. And you also want to keep the blood pressure up. I mentioned in that previous slide. Let me go back to it actually. As the RV cardiac output goes down, by definition, the LV preload will go down, and then you get reduced LV cardiac output, and then you get low aortic root pressure, and then the right coronary is perfused. So hypotension in a right heart failure patient can be catastrophic. So they can be looking fine, but if they get hypotensive for whatever reason, that RV will completely lose its coronary perfusion. So I'll talk about this in a minute, but dobutamine and milrinone are great inotropes, but they also can peripherally vasodilate you. So you can get into a lot of trouble if you get them very peripherally hypotensive. So often use a combination like dobutamine and vasopressin or dobutamine and Levophed, norepinephrine to keep their systemic blood pressure up while you decrease the PVR and you get their contractility going up. So these are some principles to sort of stabilize patients. And then, while you're doing this for the etiology, and then, if they have a PE or whatever, those have all their own treatments. But these are sort of some general principles I wanted to go through with you. And then we talked about this, but this is some more principles. So again, you're trying to optimize volume status preload, but you have to do a good exam and get as much data as you can to do this, augment the cardiac output, and then reduce the PVR. One of the sort of, again, underrated things I think about this is that, it's not just using drugs to do this. You also want to correct all the metabolic derangements that are common in your ICU patients. For example, anemia, respiratory acidosis, or metabolic acidosis. If they're hypoxemic, you want to fix this. All of these things can cause increase in pulmonary vascular resistance. Elevated CO2 levels, low oxygenation, the lungs are going to respond unfavorably to that by clamping down. So you want to really work on these. If they do need to be intubated, you want to use the lowest pressures you can, use lung protective ventilation strategies, and not you can use some liberalize the CO2 goals a little bit, but just keep in mind that will increase the PVR. And you also want to reduce sympathetic overstimulation. So a patient who's in a lot of pain or gets stimulated by an endotracheal tube, they're going to be very sympathetically stimulated. They'll bear down, and that can also increase PVR. And then the final principle is keeping the SVR up, which will keep the right coronary as perfused as possible. So keeping their mean arterial pressure, systemic arterial pressure up, while keeping the PA pressures down is kind of the main. So these are some of the common drugs that we use as inotropes and vasopressors, particularly in right heart failure patients. This is as much of an art as a science, I think. But again, the principles are that you want to increase inotropy, decrease the pulmonary vascular resistance, and increase the mean systemic arterial pressure. So there's a lot of great drugs for this. I like this table because it shows you what each of these drugs does for the cardiac output, the pulmonary vascular resistance, the systemic vascular resistance, then your risk of arrhythmias. Patients with right heart failure do not tolerate arrhythmias very well. So you want to be mindful that a lot of these drugs, especially at higher doses, can trigger arrhythmias. So dobutamine is a great drug. It's, you know, a well-known inotrope at these different doses. At low doses, it possibly decreases PVR, but it's well known, especially at higher doses, to decrease systemic vascular resistance. So I can remember one patient about a year or so ago in particular that was doing great, but then quickly became systemically hypotensive on milrinone actually, and got into a lot of trouble with that. So you just have to be very mindful. And again, you can combine these drugs. So something like dobutamine and vasopressin, very different mechanisms, which will help you keep up your cardiac output, decrease your PVR, but keep up your systemic vascular resistance. Dopamine is another one that increases your cardiac output. It's not really clear what the effects on PVR, but at higher doses it probably does. So you want to be careful with this one, but it also increases your SVR. And then epinephrine is also a great drug to use in these patients. It really increases your cardiac output. It may decrease your PVR, but it also keeps your systemic vascular resistance. So epi actually is usually the first drug I reach for with right heart failure if you're still trying to differentiate things. And this is in contrast to left heart failure. You know, I hope there's no cardiologists here, but they get very against using epinephrine in left heart failure patients because you want to decrease the SVR in left heart failure patients, but it's kind of the opposite in right heart failure. Other drugs are milrinone. Again, this is similar to dobutamine in fact that you're going to get a good increase in your cardiac output, but can get a pretty dramatic decrease in your SVR. And milrinone has a fairly long half-life, so if you get into trouble, it takes several hours for this to wear off. So just being aware of that. Levophed is also okay to use. It may increase your PVR, but it also increases your cardiac output and your SVR. And it's a pretty good drug to use here. And then vasopressin is another one that we use quite a bit, mostly just to keep up your SVR. And again, I like to sort of combine this with dobutamine or milrinone to make sure you don't run into trouble with systemic hypotension. One drug that you will not see on here is phenylephrine, which is a pure alpha agonist. And the reason for that is that will increase your pulmonary vascular resistance more than any of these other drugs. So it's great at keeping your systemic vascular resistance up, but it will increase your PVR as well and make your right heart failure worse. So this may be relevant to one of our knowledge check questions later, but we really try to avoid phenylephrine in any patient with right heart failure. Just a quick slide about inhaled pulmonary vasodilators and VQ mismatch for reducing afterload. So this is a quick little diagram of the alveolar unit. So this is the trachea going down into some alveoli. This is the pulmonary artery with deoxygenated blood, and then this is the pulmonary veins with oxygenated blood. So this is the normal diagram. The blood goes by the alveoli, the oxygen goes across, the CO2 leaves, and you get nice oxygenated blood. What happens is someone gets sick with a pneumonia, you know, or ARDS, this whole unit here gets filled up with pus. And what happens is this, the lungs blood vessels are unique in that they recognize this. And instead of dilating like the vessels in your foot, if they get ischemic, they actually contract to shunt the blood over here to the one that's working. So you have less blood going by the damaged alveoli and you have more blood getting oxygenated through this one. And then what you can do is if you added an inhaled pulmonary vasodilator, this actually will further dilate this good one in the one that is ventilated, won't go into this one. This actually is a little bit bigger than it should be, but the idea here is that you're dilating this one more, so you're getting more blood flow shunted around the working alveoli. So you decrease the pulmonary vascular resistance and increase oxygenation. What happens is if you give an intravenous pulmonary vasodilator like treprostinil to somebody with ARDS, it's going to indiscriminately dilate both of these vessels, and you'll actually get more blood you will decrease the PVR, but you may worsen hypoxemia as you had more blood shunting across this non-functioning alveoli. So that's kind of the end of my didactic portion. I'm going to go through a long case which sort of illustrates a lot of the principles I put here. Is there any questions? All right, I will keep going. So this is a case we had at our center about a year and a half, 2 years ago, which was one of the most interesting things I've seen. So the patient was a 45-year-old man. His only medical history was a 12-year history of recurrent venous thromboembolisms, pulmonary embolisms, who came to our emergency departments with complaints of 1 day of shortness of breath and hemoptysis, coughing up blood. And he said that 1 month prior to his current presentation, he was admitted to another hospital in our area with similar complaints, including hemoptysis, and he was found to have a recurrent pulmonary embolism despite being on rivaroxaban, which is one of the direct oral anticoagulants. And at that time, he said he was switched from rivaroxaban to warfarin, a vitamin K antagonist for his PE. He said he felt better. He said he went back to work. He was he did like lawn maintenance, mowing, that type of thing. But then it got to the point where he couldn't breathe at all and couldn't do his job, and he started coughing up blood, so he came to our hospital. Only really medical history of note was this multiple pulmonary emboli. His medications are here, really nothing else about his medical history that was relevant. In the emergency department, his vital signs were mostly normal except for his pulse ox, which was 78% on room air, which corrected to 84% on 6 liters nasal cannula. So then he was put on high flow nasal cannula. His labs were really only notable for his hemoglobin was 18, which is high. He had a normal lactic acid. He had a CT angiogram of his chest, which was negative for PE. But here I showed an image. I have an image here. We can see he has this pretty dense consolidation here on the left. So based on this presentation, he was given antibiotics for a possible pneumonia and admitted to the intensive care unit. This is his echocardiogram. So I'm going to show this is a very abnormal echo. So here you can see I have some labels here for people who aren't quite as familiar. So this is the parasternal long axis. So this is the right ventricle here. This is the left ventricle. The mitral valve you can see kind of opening here. The aortic valve is not quite in view, but it's right about here. So the blood comes in here and goes out here. And then this is the left atrium. And you can see that the RV is at least moderately enlarged and has severely reduced systolic function. There's the fractional area change here is about 13%, which is quite low, and the right ventricular systolic pressure is about 97, and the right atrial pressure is about 15. And there's also some pulmonic regurgitation in the left ventricle. The left ventricle is normal in size, but there's some mildly impaired function here. This is the same patient, just with the parasternal short axis. So rotating the probe in the same position about 90 degrees, you get the parasternal short axis. So you can see here, this again is the left ventricle. It's nice and thick here as the LV should, but then the RV is quite enlarged here. It should be, smaller. And again, I showed you this picture earlier. It should be kind of wrapped around here, and it's not. Again, here's the RV and the LV, and you can see, let me see if I can show you here, but this should be nice and round, but you can see during both systole and diastole that this septum is flat. So this isn't indicative of both pressure and volume overload. And then this is the apical 4-chamber view. So I can start this. Gives you a nice kind of 4-chamber view. Let me just show the structure. So this is the RV, this is the LV. Here's the tricuspid valve going into the RV. The right atrium is quite large here. Here's the mitral valve, and the left atrium is hiding over here. There's also a small pericardial effusion. I don't know if you can see that up here. But basically, this is a very...
Madam, can you mute everybody else, please? Sorry, Dr. Thomas, kindly go ahead.
Okay, can you still hear me?
We can hear you.
So yeah, this is the apical four-chamber, and you can see it's just a very abnormal echocardiogram, suggestive of very high pressures and volume, and the RV is basically failing at this point. This RV should be about 2/3 the size of the LV, but you can see it's probably almost twice the size, so quite abnormal echo. And then this is a special type of CT angiogram that we have here at our center called a dual energy CTA, and this gets you it's called perfusion images of the lungs. And this, it's a little bit hard to read if you're seeing it for the first time, but these green areas in the lungs are well perfused, and you can see the red blood vessels here. This is that dense consolidation that I showed you earlier. But these large areas here are blue, wedge-shaped, are actually chronically clotted off areas. So what this shows actually is chronic bilateral thromboembolic disease. And this is probably actually an infarct down here. I thought was pneumonia. So this patient was then sent for an urgent right heart catheterization. I have some of the waveforms here. So I showed you the normal RV waveforms before. So we know this is the RV, A, because it says it over here, but B, because the diastolic pressure is quite low. You can see this is a very abnormal, numbers. His RV systolic pressure goes up to almost 140. That's probably about 130 during the exhalation phase. So very abnormal. And then you can see advancing the catheter from the right ventricle into the pulmonary artery. The systolic pressure stays very similar, but the diastolic pressure goes quite up. So that's, I think, important for the fellows to know how you tell these waveforms apart. So these are suprasystemic PA pressures, which is pretty bad. So these are the full numbers from the right heart catheterization. His right atrial pressure was 20. I showed you the RV and PA. The mean pulmonary artery pressure was 88. This is definitely one of the highest I've seen in my practice. They were unable to wedge the catheter, which is not unusual in patients with this high pressures. His pulmonary arterial saturation was 49, which is quite low. And then using the Fick and thermodilution calculations, this patient had a cardiac output of around 2.7 to 2.9 and a cardiac index of 1.4 to 1.5, which is quite abnormal. And then during the catheterization, I'm not sure if the fellows have seen one of these before, but this is a pulmonary angiogram. So this is the right main pulmonary artery with all its branches, and this is the left main pulmonary artery with all its branches. And you can see on the left side down here, this is these are actually enlarged, but sort of normal distal perfusion down here, but there's a lot of areas where there's just sort of like stumps. This should be all the way out, all these vessels up here, but there's actually kind of stump occlusions and perfusion defects here. So this patient has really extensive chronic thromboembolic disease. So this is called, abbreviated CTEPH, or chronic thromboembolic pulmonary hypertension. What happens here is, patients have acute PEs. They, for whatever reason, they weren't on the right anticoagulation, but they basically incompletely resolve and become almost like scarring inside the blood vessels, and eventually this occludes large portions of the pulmonary artery. Then you get in the vessels that are still open, are receiving more flow, and they get a microvasculopathy. In the pressure goes up in there too, and then you get a progressive increase in the PVR, and then, as I showed you before, you eventually get right heart dysfunction and symptoms. And this patient was presenting very late. So just quickly, the way you assess these patients is echo, like I showed you. You can get VQ scans or CT scans. Doing the right heart catheterization. So to meet criteria for pulmonary hypertension, you need a mean PA pressure greater than 20, pulmonary arterial blood pressure less than 15, and a PVR greater than 2. And on the angiogram, you may see bands, webs, or total occlusions. The patient I showed you is mostly occlusions. And there's some, in the outpatient setting, there's a number of treatment options. All patients should be assessed for surgery with a pulmonary thromboendarterectomy. If they're not candidates for that, they can do endovascular balloon angioplasty of those lesions. And then either of those patients may or may not be eligible for medical therapy. So this is actually a picture I took of this patient's ICU monitor after he got back from the catheterization. And you can see here, this is his heart rate, this is his systemic blood pressure. Systemic pressure was 120, but this is a pulmonary artery catheter, which showed a pressure of 156/1. So this pulmonary artery catheter should be in the pulmonary artery. Is it in the pulmonary artery or no? Any of the fellows want to take a guess? All right, so yeah, it's in the wrong place, so it's probably was a little too shallow, and you can see that by the diastolic pressure is 0, so it's in the right ventricle, not in the pulmonary artery, so it needs to be advanced. And you can see the patient's very hypoxic, but this is very abnormal. Normally it should be 20/5 or something with this blood pressure, whereas I'm still quite not sure how this patient was alive at this point, but there it was. So this patient, he was, starting to be in cardiogenic shock with right heart failure at this point. So we started him on inhaled nitric oxide, and then, these are some more of the chronic management of pulmonary hypertension medications. But given that he was so sick, we tried to start him on riociguat, an intravenous Remodulin, which is prostacyclin, and just to review the mechanism of that is trying to reduce the PVR via dilation of those non-involved vessels of the embolic disease. We gave him aggressive diuresis with loop diuretics, and then we switched his warfarin to a heparin infusion due to his hemoptysis. And then unfortunately, after that night, the patient developed ongoing massive hemoptysis. And then in these patients in particular, chronic right heart failure patients, there's a number of mechanisms for this. So here's some pictures over here. This is an acute PE, and you can see over here normal bronchial arteries. That's the systemic blood supply to the lungs for oxygenation. But what happens when you get chronic PEs and chronic pressure elevations, these bronchial arteries start to hypertrophy to give the lungs more blood supply. And then there's also further down, there can be more aortal pulmonary collaterals. Basically, there's more systemic perfusion of the lungs. And then if you give a patient like this too much pulmonary vasodilators, you'll overdilate these functioning blood vessels. In all those, if the pressure gets too high, they can burst and bleed into the lungs, and the patients can have massive hemoptysis. So this patient, unfortunately, despite treatment, became more and more hypoxemic and required intubation. I want to do a quick few slides about intubations in patients with RV failure. This is a kind of a tricky topic, and I'm sure the fellows are interested in this. But I alluded to this before, but there's a lot of pitfalls to this. This is not your average healthy patient or pneumonia patient. They have severe hemodynamic compromise. So I'll talk a little bit about my approach to this. It's again, just like a lot of medicine, is just as much as art as a science, and you want to do your reading, but you also want to feel out the situation, and not every situation will be the same. So one important thing to know is that a lot of the sedatives and induction agents we use in the ICU can really quickly and dramatically drop the systemic vascular resistance, or the MAP, which can worsen leftward shift of the septum and decrease cardiac output, and then again goes back to decreasing right coronary artery flow, which can precipitate worsening RV failure. And then some induction agents, I'll go through these in a minute, but are actually direct myocardial depressants and can raise the PVR, both of which are bad in right heart failure patients. And then sympathetic stimulation, either the patient getting really anxious about what's about to happen, or you putting a blade inside their throat, or a tube that can also make them tachycardic and bear down, and that can really precipitate worsening RV failure too. So it's important to have adequate analgesia in these patients. But the flip side of that is if you wait too long, the patient needs to be intubated. If they get more hypoxemic, more hypercarbic, more acidemic, that's also going to make things worse. So it can be really tricky, deciding on timing. And then also, once you put them on the ventilator, as I said, if you use too high pressures, that can cause direct compression of the pulmonary artery vasculature, which can increase RV afterload and PVR, which can make things worse. So you really want to avoid overbagging. These situations can be hectic, as I'm sure you've seen, and people can really just slam on the bag. So you want to avoid that. You want to avoid high PEEP, and then use your low tidal volume ventilation. So some of the drugs that you use, so propofol can actually decrease the pulmonary artery pressures and the PVR, but you also have to be careful because, as I'm sure you all know, it can decrease the MAP as well. So this is one agent in smaller doses you could use as an induction agent. Fentanyl and other opiates are great drugs to use for these patients because it can calm them down. It can reduce sympathetic stimulation. It doesn't really have a direct effect on PVR, and it has pretty minimal effects on systemic vascular resistance, at lower doses. When I was putting this talk together, I found some data that etomidate, which is my preferred induction agent, can increase PVR, though it is sort of the recommended induction agent here. It has very little, it doesn't affect the myocardium. It doesn't affect really the systemic vascular resistance. Some things you want to try to avoid are ketamine. That can increase the PVR. And then the volatile inhaled anesthetics can increase pulmonary vascular resistance as well. We don't really use this in the ICU, but if the patients need surgery, you want to be aware of this. And then nitrous oxide can also increase PVR. So you kind of want to stick to some of these here at the beginning. So my approach to these patients, number one, use as many resources as you can. It's very rare that the patient needs to be intubated, in the next 30 seconds. So take a few minutes, collect yourself, put a plan together in your head. In our ICUs, there's usually 2 docs on during the daytime. So I almost always ask my colleague to come and help out. If you have time, putting an arterial line, a radial art line in place is very helpful. So you have continuous blood pressure monitoring so you can respond to any quick drops in systemic pressure. Having a PA catheter in place is less helpful because you can't really directly, affect that, but it's good to be aware of if the pressures are going up or down. I always have pushes of drugs available, so I prefer push dose epinephrine in 10 micrograms per milliliter in the syringe, and then I usually put my colleague or someone else working with me in charge of managing the hemodynamics while I'm focusing on the airway. I almost always, if they're not already on an inotrope infusion like epinephrine, I just put them on, a few mics of epi just to get that marinating and keep the systemic blood pressure up, keep the RV pumping. You really want to pre-oxygenate these patients, again, avoiding hypoxemia, that delay between taking off the oxygen and putting in the tube. You don't want their sats to drop, so oxygenating them as much as possible. You can do rapid sequence intubation in these patients. I tend to pre-medicate them with an opiate, like 50 micrograms of fentanyl, just to kind of calm them down, and then maybe using a little bit lower dose of etomidate or propofol so you don't totally tank their systemic blood pressure. A lot of these patients are pretty out of it to begin with, and then I do usually use paralytics like rocuronium. There are alternatives though. So doing something like an awake fiber optic intubation, you sit the patient up, you give them a little sedative like fentanyl and Versed, get them sleepy, still awake and protecting their airway. You can numb up their throat with some lidocaine if you have this available in the ICU, pre-oxygenate them, and then use a bronchoscope with an endotracheal tube loaded over it, and you can kind of sneak the tube down past their cords while they're half awake. And, we do this all the time with awake bronchoscopies. So it's sort of the same principle, but you just don't want to, stimulate them too much or make them too hypotensive. And then if you have ECMO or other devices available at your center, or the patient is going for surgery and needs to go on bypass, you may consider, cannulating them while they're awake and avoiding this whole thing altogether. So my biggest piece of advice would be take your time. Don't, these situations are always hectic, as you've all seen in the ICU. Take your time, get your resources, get a plan in place, plan A, plan B, and have backup in case things go sideways, which they often do. So our patient, he was started on an epinephrine infusion, for inotropic and systemic blood pressure support. They had time to play. This happened in the middle of the night while I wasn't there, but they had time to place an A line. They gave a little bit of fentanyl, etomidate, rocuronium, and used the video laryngoscope to place an ET tube. The intubation itself went okay, but unfortunately the patient developed worsening hypotension, and several hours after the intubation, it may be that the vent, precipitated this, I mentioned, requiring escalating doses of epinephrine. They added norepinephrine and vasopressin, but despite this, the patient had a worsening lactic acidosis. He started to develop renal failure and congestive hepatopathy. So what are the next steps in this patient? So he sort of failed medical management here at this point, and has not really been treated for his primary problem. So this is when you start to think about mechanical circulatory support in patients with RV failure. So I'm not super familiar with the centers of the fellows here, but every center has different things they're comfortable with, different things available. At our center, we're lucky to have basically the full spectrum of mechanical circulatory support. So these decisions are not made by one person or one doc or whoever's taking care of the patient. We always involve people from different teams. The intensivists, what the primary issue is, the pulmonologists, cardiologists, the surgeons who are going to put the devices in. This should be a multidisciplinary discussion. We have a whole system set up for that. And then thinking about the patient, you want to incorporate different variables, like why is this patient in shock? What are their other medical issues? What are their hemodynamics? Are they going to survive this? You never want to put someone on a device that doesn't have a clear path to survival. Those can be very different things. They might just need time. They might need a surgery. They might need a transplant. But you want to be thinking about all this ahead of time and thinking about their kin, and not just putting everybody on indiscriminately, because you're going to cause a lot of problems. This I'm going to go through quickly. There is a lot of different devices available for RV support. There are some of the devices that can be inserted percutaneously, so things like the Impella RP and the Impella RP Flex. These are like single peripherally inserted devices that go in through the venous system, are threaded much like a pulmonary artery catheter through the RA, RV, and into the PA. And this is actually a whole pump housed in here that takes blood from kind of the RA, IVC, SVC junction and pumps it directly into the pulmonary artery. So there's sort of different configurations of these with the Impella RP and the Flex. And then something like a Protect Duo, similar concept, except the pump is outside the body. And you can add an oxygenator to this. But these are basically just direct RV support. So these are good in patients who have primary, pump failure, like an MI, or volume overload. But in somebody with an afterload problem, these really aren't going to help much at all, and in fact may make things worse. So that's why you want to think about what the primary problem is. And then getting a little more advanced, surgical RVADs are implanted, during or after cardiac surgery. Similar concept, you're taking blood from the right atrium, going out of the body into a pump, plus minus an oxygenator, then back directly into the pulmonary artery, bypassing the again, similar things, this supports the right ventricle, but it doesn't really support the LV, and it's not really going to help much if there's a problem distal to here. It's more if the problem is over here. And then sort of the most advanced thing you can do is full veno-arterial ECMO, which supports both ventricles and oxygenation and importantly bypasses the pulmonary circulation. So if they have a PVR RV afterload problem, this is going to be your one of choice. So you can cannulate patients peripherally via the groin most commonly, or sometimes in the setting of cardiac surgery, the surgeons will cannulate the patient via the right artery directly into the aorta. And peripheral cannulation, I think you can see a little bit here, blood is drained from the femoral vein and returned back to the femoral artery into the aorta. It supports biventricular function. Again, this is from that same article I mentioned earlier that just came out a few weeks ago in the Journal of Heart-Lung Transplantation. It's a great article with some good, if the fellows are interested in reading. So our patient, had, again, this fixed pulmonary artery obstruction and needed right ventricular support and oxygenation support. So he was cannulated for full VA ECMO through the right common femoral artery and vein. And he also had a distal perfusion catheter placed to perfuse his right leg. He had immediate improvement in his hemodynamics and oxygenation. And his drips were able to be lowered quite a bit down to epinephrine 2, norepinephrine of 3 mics. And he was actually rested on VA ECMO for about 12 days to decrease the pulmonary artery pressures, and it led to resolution of his hemoptysis, and he was able to wake up. And then he actually on ECMO day 12 underwent a surgical pulmonary thromboendarterectomy. And this is the actual specimens that were removed by our surgeon, Dr. Tang, who does all these here at our center. So these are quite large chronic thrombi that were removed from his right and left pulmonary artery. Patient did have a quite complicated post-op course. He had an ongoing hemoptysis. Unfortunately, he had chronic renal failure, ended up on dialysis, but he actually did make it out of the hospital. And we saw him in clinic a few months later, and he was living independently, and his echo had actually normalized. His RV size and function were normal. He had no appreciable tricuspid valve jet to measure RVSP. So had a overall great result. That's the end of my case. So this is just a quick summary slide. So, hopefully we realize that RV failure is an important cause of morbidity and mortality. Most important thing is to accurately diagnose that they have RV failure, and then what is the etiology of their RV failure, because the management is very different. When patients fail medical management, if it's available, you definitely want to consider mechanical circulatory support. This may require transfer to a different center, that if you don't have it, but you want to be thoughtful about this. Not every patient should go on. You want to have a clear path, or at least because it's not fair to the patients or their family if they wind up on ECMO or something with no exit strategy. And then I think at our center we're very good at multidisciplinary care, but everyone in your hospital is going to have a little bit different expertise, and these patients are sick and complex. So it's always good to ask your senior colleagues and colleagues from other disciplines for help. So that's the end of my talk. I have a few knowledge check questions if we want to do that. I think there's stuff going on in the chat. I just can't see it. Maybe someone could read them, right?
So Chris, Dr. Desalegn would read out the questions on the chat for you. Okay.
Okay. Thank you, Dr. Chris, for the comprehensive, well-elaborated presentation. We have learned a lot. And I will read, there are a few questions on the chat box.
Okay.
One of the questions says, do we have biomarkers to detect early right side heart failure?
Yeah, that's a great question. I think, I didn't really mention this, but we use BNP and more commonly NT-pro brain natriuretic peptides. The utility of those is kind of questionable in the ICU environment. I mean, certainly if it's sky high, that's a clue to that there's some heart failure going on. And if the patient has that, diagnosis like pulmonary hypertension or something going on before, it's a good device to, or a good lab to trend to see if things are getting worse, and you can kind of correlate it with their symptoms. But it's not something that I typically use, on a daily basis in the ICU. It's not really that helpful there, but you can trend it over time. But I think if you're worried a patient's former level of care and things are slowly changing, checking it on that patient when you have a baseline could be helpful, but it's not a perfect test. But that's probably the most useful biomarker. And then of course, things like lactic acid and renal function, urine output, all your usual markers that you look for perfusion is what you kind of use more on a hour-to-hour, day-to-day basis.
Okay, thank you. The other question is, it says, what role does patient blood management related techniques play in management of RV failure in ICU? I think what I understood is if patients require transfusion is indicated, is there something special we do about these patients with RV failure in ICU?
That's a good question. There's a lot of it's been studied in a lot of different environments about what, oh, here's the chat now, what is sort of the correct transfusion threshold. I think that I tend to use 7 as my threshold. If they have like a right MI or something like that, you might go a little bit higher. You do of course want to be aware of that. If you're giving blood, that's quite a bit of a volume load, even though it may be a few hundred milliliters. It's very concentrated with proteins and cells and things. So often if the patient is overloaded, you might chase it with some diuretics. But yeah, certainly you don't want to let your patients be too anemic. And this patient that I presented had a lot of anemia and had to get a lot of transfusions.
Thank you. I also have similar question with regard to fluid administration in RV failure, especially in acute MI, without feature of pulmonary edema. Previous guidelines recommend relatively generous fluid administration, 1-2 liters. How is this seen now? Is there any change? Ongoing studies are there, and there are some controversies. I want you to explain for us more.
Yeah, that's a great question. To be honest, I am not super familiar with the sort of ongoing controversy there. I think the idea is that when they have just isolated RV stunning, you want to give it a little more preload to cause adequate stretch and give it back a little bit of its contractility. I think giving some fluids is okay. You don't want to give it too fast, and then you want to. In our center, we put pulmonary artery catheters in these patients and frequently check their wedge pressure. So you want to be mindful you don't shoot their wedge pressure up to 20 or 30, because that's going to precipitate pulmonary edema. So I think you probably do want to give some amount of fluids, whether it's 1 liter, 2 liters. I mean, that's going to be different in every patient, but you just want to keep an eye on the things that could go wrong, which is, pulmonary edema or just worsening congestion, that type of thing. So it's going to be a little bit different in every patient, but I apologize. I'm not super familiar with the most literature in that particular disease state. I see a question about metaraminol. I am not familiar with that drug at all. I apologize. we want to do the knowledge questions? They're pretty quick.
Yeah, that sounds great, Chris.
Oh, sure. Here's another question. What measurements and parameters of bedside echo are helpful to follow RV patients, especially planning to liberate them from positive pressure ventilation extubation? That's a good question. I think, echo is a great tool to use for these patients, but it's hard to sort of pin down one parameter. I think the general principle is that I focus on is their volume status. First, you want to make sure you've fixed or at least started to address the underlying issue, and their volume status will become very important. When the patients are on positive pressure ventilation, they may look great because the gradient across the alveoli keeps the fluid coming out. But if you can look on echo and see that their right atrial pressure is still really high, like 15, you might worry that taking away that positive pressure is going to precipitate pulmonary edema. And we see that for example in like post cardiac surgery patients, post pulmonary thromboembectomy patients, they look great, and then you take away the positive pressure and all that fluid sort of reaccumulates back in the alveoli. So I think the most important thing to look at is their fluid balance with that, and by looking at right atrial pressure or looking at their IVC collapsibility, which is different when they're intubated versus extubated. But I think maybe what you're asking is like looking at RV function or other things. RV function is not as helpful, and it's not going to like get a lot better. It takes weeks to months for the RV to sort of adapt. The patient that I presented, it took a couple months for his echo RV function and to normalize. And so I think probably the biggest thing you could look at with echo is right atrial pressure and IVC collapsibility. How about medications for those with hypoalbuminemia and anasarca with RV failure? That's a tricky question. So maybe patients with like liver disease, that type of thing. I mean, these patients are going to be really difficult to manage. As you mentioned, they're going to have anasarca. You can give them back albumin. You can try to optimize their nutrition, but as I'm sure you know, that's not an easy fix, and it takes a lot of time. You want to manage their volume status as much as you can with diuretics, but often those patients have kidney dysfunction. I think again it goes back to what's the underlying cause. Is this a cirrhotic patient with portal pulmonary hypertension or something like that? These are really difficult things to fix. But I think focusing on nutrition, volume status, maybe giving them back some albumin, treating anemia, trying to increase their intravascular colloid pressure to mobilize that fluid using compression stockings, ambulating the patients, but then putting their legs up. But there's only so much you can do. All right, why don't I go into my knowledge questions? These are not meant to be hard, just to sort of illustrate some of the points that I made in my talk. So which vasoactive drug should you avoid in patients with RV failure? Epinephrine, norepinephrine, dobutamine, phenylephrine, or vasopressin? All right, it looks people got 4. Yeah, and that's the reason for that is phenylephrine is a pure alpha agonist, so it's going to get your systemic vascular resistance up very nicely. So it's good in patients with sepsis and things like that, or vasoplegia, but it's not good in patients with pulmonary hypertension because it will also increase your pulmonary vascular resistance. It can make the RV failure worse. So using one of these other drugs is probably better. All right, question number 2. The right ventricle can generate systolic pressures higher than the left ventricle. So people are saying true. And in general, yes, this is true. And in the healthy state, the RV cannot generate this. But I showed you that case in a chronically adapted RV, it can actually generate extremely high pressure. So that young guy with CTEPH for probably many years undiagnosed, his RV became very muscular and adapted and can generate like a systolic pressure of 130, 140. So a little bit of a trick question, but acutely the RV cannot generate these pressures. But if it has time, months or years to adapt, it can actually get quite muscular, but it should not be that way. So if you see that, it's very abnormal. And then my last question is, all the following are important for managing RV failure except correctly diagnose the etiology, reduce the preload, augment the cardiac output, and reduce the pulmonary resistance, correct the acidosis, hypoxemia, and anemia, maintain the blood sugar between 120 and 180, and use invasive hemodynamic monitoring, arterial and pulmonary catheters when able. All right, we have 1-4. Yep, that's the correct answer. So of course, in your ICU patients, it's good to maintain their blood sugar, but not really directly relevant to RV failure. I put this one as my last question because I think if you can remember these sort of 4 principles, you can do a pretty good job taking care of your patients with RV failure. So figuring out what the problem is, directly addressing these things, fixing basic ICU problems like hypoxemia, acidosis, anemia, and then using whatever monitoring you have. I do think more information is always better. Whether it's good information or bad information, that's up to you, the doc, to decide in how it is relevant or not. But always getting more information is usually helpful. Just don't get stuck in the weeds. So that's my talk. Thank you so much for having me. This is my dog Brody. He comes in to all the end of the presentations. Hope this was helpful and enjoyable and interesting. And this is my email if anyone has questions or wants to connect.